Hello, welcome back to our second session this morning, and I'm really delighted to be chairing this. We are now going to look at the other end of the telescope, the most important end of the telescope. We started off with highfalutin policy and abstract thought, which I hope you found very useful with Matthew. And now we're going to really go to the cold face and to talk about particularly the experience of patients, because that's what we're all here for. And if we lose that, we lose everything. What we're going to do is we have three speakers. You'll notice we have two speakers. The third one is going to appear virtually on a film. We're going to have Claire Lima to start off with, who is a doctor, a paediatrician I've known for many years. She's been very busy trying to make improvements at the front line, but she had a very interesting experience recently where she was plunged into being a very intense experience of being a patient herself. And she's going to give us some insights on that in a film in 1 minute. And then I'm going to ask Jackie Dyer, who's sitting right over there to my left, to give some of her experience. Jackie, as you can see from her very impressive biography, has a lot of roles in life, but one of them is to work with the black community in Lambeth to try to support them, particularly in improving mental health and well-being. And she's spent many years doing that, as well as doing community development, and can really see things from the community's viewpoint about how the system works and where it works and where it doesn't work. So Jackie's going to say some few words about that. And then to follow and respond, we're also thrilled to have Dido Harding here sitting to my immediate left, who is 6 months into the job as chair of NHS Improvement. And clearly NHS Improvement's role, one of them is improvement, in fact, in the healthcare system. And so how Dido thinks NHS Improvement's role can be developed in future to support the front line, to make the kinds of improvements we've discussed earlier, and also in doing that, never to lose sight of the patient. So I'm very happy to ask Dido to do that. And as you see, Dido's experience is also very varied and extremely impressive, but one of them is also having intense experience in the private sector, particularly in the retail industry, in which director of convenience, I think was the term was used at Sainsbury's, which was intriguing. Perhaps you'll explain. So I think that's a very rich set of perspectives, and then we can have a discussion with all of you. So let's kick off, and we'll start off with this rather moving film, I think you'll agree, from Claire Lima. Thank you.
I work in a wonderful hospital called the Evelina Children's Hospital in London, and I work as a general paediatrician, which means I cover everything from the emergency department all the way through to the high dependency unit. What I've been doing over the last few years is trying to find areas of that work that make patient experience below what one would hope for, and then see how you can do something about it. On December the 15th, I was merrily walking to work, and I was crossing a zebra crossing, and a car hit me at rather great speed, which led to me fracturing lots of bones, some of them requiring operations, and then since then have slowly been recovering and rehabilitating. It's almost impossible to empathise or to guess what things are priorities for patients until you actually experience it. And that's given me a probably unusual opportunity to reflect on my experiences as a clinician and how those compare to my experiences as a patient. It's definitely given me an insight into elements of the NHS that work brilliantly and elements that maybe could work a bit differently. There are often people who've done little things that were really extraordinary, like the lovely gentleman who brought teas and coffees around and meals to the patients, who would remember what I liked in my tea and which particular biscuits I liked. They wash my hair. When you've spent 10 days in hospital and still have the road and all the blood and everything else in your hair, it's an incredibly different feeling when someone looks after you like that. I have never asked a patient anything about those kinds of personal cares, which actually are really, really, really important. One of the orthopaedic surgeons, when I was maybe 4 or 5 days into the hospital, came and sat next to me, and he said, "Well, tell me what you're learning." And it was that curiosity which was so, so important and will stay with me for a long time. I really, truly believe I will go back and be a better doctor, and hopefully a better supporter of healthcare as a result of my experiences. And for me, having worked abroad, it was a really, really clear indictment of how lucky we are to have a system where I didn't wake up every morning in hospital worrying about how I was going to pay for something. I didn't wake up every morning in hospital thinking about what the long-term implications would be. I could just focus on getting better because we do have such an extraordinary system of nationally provided, free at the point of delivery healthcare.
Oh, I'm a little like that today, so bear with me. Yeah, so the reason why I'm sort of in the role that I am, or I do what I do, the driver of what it is that I do, is because I'm a lived expert by experience. And when I say that, I'm a carer of 3 siblings with severe mental illness, the youngest who died a few years ago. And I have my own experience of ongoing anxiety and depression that I have to live with and manage. But what I experienced was that the system didn't quite get what the needs of my family are, coming from an African Caribbean background. And we can look around this room and we can see that there's very few African Caribbean or people from different cultures within this room. And that actually is some of the challenge that I feel that I'm up against in terms of, and I'm sure you'll have heard of the snow-capped mountain of decision-making or leadership within the NHS. And actually that's replicated right throughout the system. And so what I wanted to do is just drive forward changes within the system so that we get better decision-making that responds more closely to the needs of the communities that we serve. And that made me get into politics at a local level. And with that, I co-chaired a commission around black mental health and well-being, because in Lambeth you have a population which is about 30% of the population from African and Caribbean communities. And yet, in mental health services, they're severely overrepresented. In fact, in secure inpatient mental health services, the ratio is perhaps 80%, sometimes 90% of inpatient care is from people from African and Caribbean communities, or BAME as they like to say. I hate that term, BAME, actually. You know, B-A-M-E. I just find it like so disrespectful to shorten a whole set of cultures down to an acronym, you know? And actually, when I think of that, I also think of bami, which is a traditional bread that we eat in the Caribbean, which is bami and ackee and saltfish. And I'm like, are you talking about bami or are you talking... So anyway, let's not go down that road, right? Let's not go down that one there. So what I really wanted to do was, with the recommendations that we had from the Commission, which we co-produced with members of the community, but actually with the wider system. So it's the members of the community plus people from the police, the local authority, the health service, the CCG, co-produced a series of recommendations, and then we went down to implementation. And what I realised is that the system itself just did not have the capacity or the urgency to be implementing what were very much a holistic set of recommendations around access prevention and patient experience. And so I had to go out with my begging bowl and look for help from external from that local system. Found it, one of the players in that is in the room, Social Finance, Lankelly Trust, so that they could help me to help the community to find a mechanism to assist driving forward in improvement in a very co-productive way. And what we came across was a model around collective impact. But why is it that I thought that this needed to happen? I think the urgency was about the difficulties that the community have in accessing services. And in accessing services, people from African and Caribbean communities actually do make, current research shows that they do make quite a lot of attempts to access services at a primary care level or through other ways and means. But what happens is that they're not understood as they are coming with anxiety or depression or whatever other sort of like mental health sort of like trauma. So the system resists opening up to receive them. And then what happens is that those illnesses become more and more and more acute, more and more profound. And the additional issue is that the community are very frightened of the services because of the experiences of death in mental health care. You saw the myth is, which is based on reality, as you know, like Sean Rigg and so many others. I don't even want to name them because it brings up a trauma inside of me. What happens is that we talk amongst ourselves, if you go into mental health services, you're going to die. They're going to medicate you, you're going to lose your life, and that's it. So there's a massive avoidance. So then you get this trajectory where we end up coming into mental health services in crisis. So how do we try and change that narrative? And the narrative is to actually work more closely with the community so that there is this addressing this mistrust, and it's very, very seriously, deeply entrenched element of mistrust. Some call it like the circles of fear, because there's fear on both sides, and start building these trusting relationships. And so what Black Thrive, which is the partnership, Black Wellbeing Partnership that I chair, that I drove forward to take place, is a systematic approach to a systemic issue, yes? And so when you look at, for example, the Race Disparity Unit, are you aware of the work that the Race Disparity Unit, one of the things that Theresa May commissioned to actually start addressing some of the burning injustices that are around the place, whatever your politics, you know what, right? I'm really happy about that piece of work. Why? Because it makes transparent what the Black community have forever and a day, decades been experiencing, but yet we don't want to talk about it. We want to say, oh, it's not really happening because the data isn't really there. Now, what that data shows is that there is a systematic process of detentions, of exclusions for certain communities in employment, in health, in mental health, in criminal justice, in education, youth offending. If you look right across the system, everywhere the public purse is paying for, right, there's an over-representation or under-representation in the better ends, over-representations in the more restrictive ends of these communities. And yet we make up, what, less than 3% of the total population of England? And yet every headline you find is about very negative around Black communities, and I'm seeking to work in partnership with the system players to address this issue, because we want help earlier, so the prognosis is so much better, and that all our diverse communities can live happier and more fulfilling and inclusive lives. And that's why I do what I do.
Thank you very much. Can I just abuse my position as chair, just ask you a quick question? It's very moving what you say, and areas of hope where you've really seen progress, Jackie, what sort of things can you point to?
So some work that actually I'm doing with NHS England is actually something that I see progress with, and that's around the Secure Transformation Programme. I'm a mental health equalities advisor for NHS England, and I see some really constructive work there where we're actually piloting a programme in secure inpatient settings because of the levels of different treatment that takes place within the inpatient settings between Black people and their white counterparts. And I mean, you wouldn't really understand how different it is unless you sort of did that sort of research. And we researched around medium and low secure, getting in particular what the Black experience was. And there is this kind of, we have to start really dealing with unconscious bias, institutionalized racism, unconscious and explicit bias, actually, because it's not just all about it's located in the unconscious, it's across the spectrum, and actually tackle what one might call the wicked issues. And that's a site that's prepared to help to deal with, you know, doing things, opening up to that experience, when actually the system normally is quite resistant to even naming these issues, never mind looking at the how can we tackle these issues. And that's the kind of more adult conversations that I'm really interested in having. And so there's windows of opportunities where you can navigate through having those conversations that lead to, right, we're going to work with Black people rather than to Black people, over Black people, for black people so that we all achieve better outcomes. This is for all of us as practice. Who wants to have a reputation of actually as a professional in a healthcare organisation where actually you have good outcomes for certain populations, but for the others you can never quite get it right? Who wants that reputation? I don't want that reputation. I don't want that reputation from my neighbours and counterparts and fellow practitioners. So I'm into the agenda of let's work together on this, because this is a win-win. And so I can see what's happening in the community is that they feel hopeful, particularly in Lambeth, that, oh my God, at last something is here that's going to help us to get better outcomes, that's really genuine, because that what they're accustomed to is loads of platitudes, but without the mechanisms to actually take them from where we are now to where we are over there. So it's like that.
Yeah, thank you very
it's
much.
Creating hope.
Yeah, okay, thank you. You mentioned unconscious bias to the black and ethnic minority community. Matthew, I think, was also implying a subconscious bias towards technology and against management culture that was conducive, particularly in a very pressurised environment. This is something that we've got to try and fix, haven't we, if we're ever going to get faster discovery at the front line, a more porous system when it comes to listening to patients. Dido, you're in the unenviable position of sitting atop NHS Improvement, and your early thoughts on that, particularly having just entered the NHS relative to where you've come from, would be very valuable here.
Well, I guess, as you say, I've got 6 months' experience of the NHS, so literally nothing. It means that at least I now have a rough idea of what I don't know. 6 months ago, I didn't even know that. So forgive me as I sort of trample along, undoubtedly treading on landmines. But I guess I come from a perspective, I spent the last 7.5 years running a technology company. But my background is fundamentally running consumer organisations, mass market, sort of consumer service organisations. And I think that technology is changing literally everything in society. But actually, the secret technology, and I didn't hear Matthew today, he spoke at the NHS Improvement Workforce Conference 2 weeks ago, so I have a hazarded guess of what he would have said. But I think that you have to remember that technology is morally neutral on all issues. It's human beings that do good things or bad things with technology. And I think we're the generation that remembers a world, broadly, a civilized Western democracy that broadly worked without technology. And we've got to work through as a society what the social, moral, and legal scaffolding is for a digital world. And the health sector is an area where that is at its most acute, because we care so much, rightly, about our health provision. It matters so much both nationally and individually to us all. And technology has the potential to bring massively better outcomes, but also brings potential for very scary things as well. And in the end, the secret to harnessing technology, and I know Matthew would have said that, is about people. It's not about the tech at all. The tech's easy. The bit that's difficult is how we can, work out how we want it to work for us. I always joke, how really, really annoying it is each time Apple do an iOS update and the way your phone changes. That's how everyone in any organisation feels when any part of tech changes in the way they do their job. Even when it's for the good, the initial reaction is one of fury or irritation or disgruntlement, because it's forcing you to change. And so it's really hard to deliver good tech-based change. And yet that's touching every element of life, and therefore every element of the NHS. And it's certainly touching, to the heart of your question, the way that good leaders lead and the way that good managers manage, and making it in some ways easier, in some ways harder. I always say the ability to work remotely actually makes it much harder to be a manager. In a world where I knew whether or not my team was happy, engaged, and working hard because I could see them, it's much easier. How do I know my team is happy, engaged, and doing a great job when I can't see them? Actually, it requires me to be a much better manager. I need to have much better performance conversations with my people. I need to know them better. I need to be able to read not just their body language, but their electronic language. I need to change how I behave to know what they're up to. And that's really hard. That's hard whether you're managing a team of district nurses. It's hard whether you are leading a team of consultants. It's hard in my own old life if you're leading a team of engineers and call centre agents. And I think we underestimate the leadership and management challenge, the opportunity it brings, but also that it's every bit as important a skill to hone and learn. I've been joking with doctors and nurses I've been meeting in the last 6 months that it's much, much easier to teach them to be great managers and leaders than it is to teach me to be a doctor or a nurse. But nonetheless, it's a skill that needs to be taught and honed and practiced. And we are never too good at it to not practice. And I think there needs to be a bit more discussion about what those management and leadership skills and behaviours are that really bring the sort of transformational change that Claire and Jackie are talking about. By the way, both of them have role modelled some of those key ingredients, the adult behaviour and adult conversations that Jackie talks about, the ability to put yourself in the service user's shoes, which is really hard to do. But actually, people who transform services in any sector, any part of the world, do it because they really understand what the service user needs and wants, and they have adult conversations with the people around them to try and move in that direction. And, you know, I'm very mindful, the sort of physician, heal thyself cry. My own organisation is far from perfect in this endeavour. And we have a huge amount of work to do to change the way we lead and manage our own teams, let alone how we then try and role model the right behaviour set for the sector as a whole. Sorry, that's a bit of a random stream of consciousness around the theme of management.
It's very helpful. Just to link the three conversations, I suppose, even more. I mean, you started off by talking a lot about the digital world, which is clearly going to change everything. And it may well bring the kind of experiences that Claire had and Jackie's experience with communities right into the boardroom in a bigger way. There would be nowhere to hide for boardroom members. Have you seen such a revolution in all the businesses you've been involved in, and how that might be facilitated as opposed to induce fear around the board table?
Well, remember, I'm a retailer. So by trade, I spent 15, nearly 20 years as a retailer, selling baked beans, I used to say. And retailing, it's really easy. You don't need tech. You walk out into the shop and you start talking to people. You walk up to customers and say, hi, how are things? Are we doing a good job today? What do you like? What you don't like? You walk down the bank of checkouts in a Tesco and people will always tell you. People on the front line in any organisation, customers or service providers, always know what's wrong. They might not be able to articulate what needs to change to make it better, but they can always tell you what's wrong. So for me, I just grew up knowing that that's how you lead. And I found when I went into a technology company, into TalkTalk, I found like I was blind all of a sudden because I couldn't walk out into the shop. And so what I used to do in TalkTalk when I arrived first was I went out to the call centres that were all offshore, or almost all, in India, Philippines, South Africa. And I personally went and I sat with the call centre agents and I talked to them. And they were the closest I could get to customers. And I'd listen to calls with them. And occasionally I'd interrupt the agent and whisper and say, let me speak to the customer. And I'd talk to the customer. And I do that once and the whole floor was listening. Oh my goodness, there's a manager speaking to a customer. And I got energy personally from that. And I'd come back to the UK, to Manchester or London. And the team would deny everything I'd heard. And tell me, no, that's not what customers really think, that's not right. And it took me several years of the cycle of them starting to realise that actually I was going back next year and I was going to have the same conversations and I'd come back on with the data from the agents again. And although there wasn't technology helping me, actually I've always found that one of the best ways is fundamentally role modelling what the behaviour you seek in your organisation. So now, I'm very proud of the way TalkTalk listens to its customers. And the team I developed and worked with, they all do this now. By the way, the ops director, when I arrived, had never visited these call centres and didn't like international travel. It's not brilliant if you've got an outsourced call centre operation overseas. And the team learnt that maybe that's a better way to lead. So I think that technology can help, but it's the human behaviours that drive it. and the personal, genuine role modelling. It is incredibly hard to properly hear, real customer feedback. I learnt it from my old boss, Charles Dunstan. When you're in really difficult times, if you just do what customers want you to do, things have a habit of working out okay. And I learnt that through the Talk cyber attack, that actually, when faced with an existential, life-threatening, organisation-threatening problem, we tried in that difficult circumstance to do what we thought was right for customers. And the media and the sort of chattering classes thought that was totally wrong. I got a lot of personal criticism for being naive and saying I don't know several times to John Humphreys on the Today programme. And a lot of CEOs think I would have been better keeping quiet for a few weeks. Don't quite know how I would have kept lying about what was going on, but that's a lot of people think that's the lesson. Don't do what TalkTalk did. Don't go out and say you don't know. We think it saved our organisation and our business because customers thought we were trying to be helpful. We were trying to help them. We were being honest. We were acting with integrity. We were being authentic. And in times of trouble, we were out there offering them free credit checking, saying, I don't know, but I'm working on it, and keeping going. And actually, the modern social media world means that if you're leading through a crisis, you have to go out and talk, because otherwise someone else fills the vacuum.
Yeah.
And so I think I haven't got a better answer than I think it's really important that leaders role model the behaviour they seek in a digital world or a physical world. And we're trying to do that. You can all help me in my quest. I'm trying to develop a volunteering scheme for NHS Improvement. It's my only chairman's foible so far in 6 months, which is I want to find a way to get everyone in NHS Improvement to spend at least a couple of days helping on the front line in January. And helping could be, just as Claire said, making cups of tea or running errands around the hospital, just being human and available. You have no idea how hard this is. My own organisation can't see at the moment how it will make us better, and just think I'm trying to sort of provide some free labour, and actually what I'm trying to do is change the culture of NHS Improvement. And the trusts we're talking to, not universally, but a lot of them can't understand why it would be helpful and think it'll be, God, I don't really want the regulator in here in January, actually in A&E at 10 o'clock at night. That could be really dangerous. And yet I'm absolutely certain that seeing is believing, and that the way we change the culture throughout the NHS as leaders and managers is by seeing it in the way that our patients see it, as Claire has just said. And so, as I said, I'm trying not to say, chairman says, this is the one chairman says thing I'm desperate to try and make happen.
Actually, thank you. I must just tell you a funny story. One of my jobs in the 20 years plus ago was I was working for Alan Langlands, who was then the chief executive of the NHS, and this involves sitting at the NHS executive board meetings once a month. And one of these months, Alan made the regional directors, because we had regions then, go out and spend 3 days on the shop floor. And I was present at the meeting when they all came back and reported, and you've never seen such a set of sort of sorry tales that we just didn't know. And somebody was carrying a stretcher and dropped the patient. I mean, it was very hilarious. That was one of the regional directors. No, sorry, I shouldn't laugh. But I'm laughing about the case of not the patient. Sorry, who was fine. It was the director who was in shock about the skill it took and how it was difficult to carry the patient and so on. But everybody had a salutary tale, and it was the most exhilarating board meeting of all of the ones I had to attend, I have to say. Sorry, patients, I do. But thanks. Just before I open this up a little bit more, just going to Jackie now. Jackie, clearly a lot of your work, absolutely as you say, and as Dido says, is to foster more communication between them that are making decisions and them for whom decisions are being made, to empower both of them a little bit more. And I can see a lot of your work in that respect. I wanted to make a smaller point, which is to ask you about technology and whether you could see any signs that new forms of technology, digital social media, could help you in that, in reaching your communities, in helping get organised community empowerment.
So one of the things that I've been trying to cultivate is actually the better use of technology in order to communicate more consistently and regularly with community members that are not able to attend, like our working groups. So, for example, we have working groups, one which is around access, one which is around prevention, another which is around the patient experience and the carer experience, another which is around the shared measurement system, which is about transparency of the data so that we have a better dialogue between what the system does in terms of like key indicators, and that the community now starts to understand what it is and whether or not we're making progress on these measures, and the community are totally involved in developing what the key indicators that they want to measure progress as regards. So for me, it's actually quite complex to be really quite organised around this. Although we have 60 regular, committed working group members that operate as volunteers, they go stretch themselves above and beyond. Not everybody is able to attend those meetings. So for me, I'm trying to use Slack. I don't know if you know that communication tool, which is a way that you can, instead of email where you get confused about what's been from who and whoever, it has particular communication channels you can set up along particular themes, and then you can have conversations within that which are much more focused. So I'm trying to cultivate that, and it's quite difficult to get people from laggards I'm an early adopter, and to get them over that distribution curve to like promote it, but I'm persistent, and so over time more and more people are using it, and then they go, oh, that it really works. And in fact, it's another tool that I'm using with the Department of Health in terms of the Mental Health Act review, and my African and Caribbean working group that's in that is using the Slack in order for us to work more efficiently, because we're not always able to be physically present. So there's a balance between using technology, I would say, to get really efficient at, but also the face-to-face element that we can't avoid, because that's the bit that really builds up trusting relationships, and particularly that is very important around mental health. But I do think there is, like, in order to engage with a really busy sort of like community that are like, you know, hand to mouth really, every minute is trying to survive really in order to move from surviving to sort of like thriving. One of the things that I'm really considering is about using more blogs, using webinars actually, because that has been really successful in terms of engagement with NHS England in my Advancing Equalities role, is like using webinars to support commissioners and providers throughout the country to tap into, like we've had a series of webinars around supporting people to look at how can we advance equalities, so to educate about each of the protected characteristics under the Equalities Act, and have a session, a webinar around each of those protected characteristics. So at the first webinar, which was around like an overview, and we touched on some race inequalities kind of like issues, and then looked at, you know, what are the challenges that you're facing out there, what are some of the solutions that you might have, you know, how might we support you? On our very first webinar, the system actually crashed. Why? Because so many people were wanting to tap into utilising that piece of digital forum, but the system wasn't accustomed to dealing with it. But as we've subsequently gone forward, it's improved, and this is the kind of way that you kind of like make improvement. But also what that said to me was about how important it is that people are out there across the country struggling with addressing mental health inequalities and looking for help, looking for those conversations to be had. And actually we've got a digital tool to help us to reach out and have those conversations, and that's what we did.
Yeah. And just last question for me. Do you see any NHS trusts in your area reaching out positively, not just to provide information about services, but to foster a dialogue in this way?
Oh gosh, Slam, I have to say, big respect to them, because actually that's who our communities are engaging with, and they've experienced some of the worst fatalities, atrocities in relation to mental health deaths in care. So Olasena Lewis, that 23-year-old boy that died fairly recently, Sean Rigg, which was the trigger, the catalyst for the Black Health and Wellbeing Commission in Lambeth, which I co-chaired. They've reached, so some of our recommendations, about 4 of them, were specifically about how do we improve some of the issues that are pertinent, particularly to the black community, in order not to repeat these tragedies. And they've taken their senior team to work directly with the community, with us, along over the past couple of years to work around issues around medication, around control and restraint, to work directly around the policies and the procedures of the mental health trust to make the changes make some kind of difference, and also to engage with community members to work with the mental health trust around specific quality improvement projects. We've got 4 just recently that have been agreed by the board, right, and that are now going to be activated. This engagement of not to but with it, this co-production kind of a way forward is actually the only way forward. We don't have capacity otherwise, and it's very, very positive and constructive. Matthew Patrick. Yeah, he's my bro.
Thank you.
He is.
Yeah. Someone tweet him now. Right, thank you. Thank you so much. Okay, we've got some time for questions now on some of these themes that have been brought up. Who's got a question? Christine, I see there. Thank you. No, it's just coming there. Thank you.
Thanks.
We'll take a couple of questions.
Christine Hancock, C3 Collaborating for Health, which is a charity about preventing chronic disease. I'll come back to it, but I wanted really, like Jennifer, to turn back to my earlier career. And particularly when I worked at the RCN, I can remember going to a hospital after a big disaster and going to see the nurses and finding I can't remember, general manager or administrator, doing a wonderful job in managing things like the press. And he said to me, I haven't dared go round the wards. I don't know what I could say to people. And I think that people often underestimate the reality of listening in the health service, or the reality of listening to black people who are angry and being treated badly. And it's not the same as listening to customers. I'm sure Dido doesn't think it is. And it's really hard for those of us who've got clinical backgrounds. We know how to do it. We grew up doing it. But for the large number of people in the service who are keen and who are there because they care about those things, they don't always feel comfortable or know how to do it. And just on my proper job, we've been using a technical tool to help local communities in very poor areas actually look at how healthy or unhealthy their environment is, with the aim that they can start changing some of those things. And we've provided very small grants. And I have to say, I'm amazed in just about a year in poor areas of Halifax and South Ayrshire, we've actually engaged a third of the total population in low socioeconomic areas. I've no idea whether the technology is doing it, we're doing it, or what. But sometimes it can be a very interesting hook, even though it's not the whole story. Sorry, 2 comments rather than questions.
Sorry, what technology did you use?
Use a tool called CHESS, Community Health Engagement Survey Solutions. It actually grew out of some research in Mexico, China and India to assess environments and how easy or difficult it was for whole populations to live healthily. And it's a real serendipity in that the people from Yale who developed it found it was very expensive using researchers, so they started to train local people to use it, and surprise, surprise, found they didn't just use it perfectly well as a research tool, but they got very excited about what ought to be done and what could be done.
Thank you.
Happy to talk more.
Thank you. Let's just take another question. There was one there. Thank you.
Thank you very much. Karen Leitz, I'm from the University of Bristol, a clinician and a researcher focusing on improving outcomes in newborn babies. As far as I'm concerned, the jewel in the crown of the NHS is the NHS number. And I don't think we've really, sort of grasped that to its full potential. How do we convince the public that we can use all routinely collected data in the NHS to use for research, in the form of a birth cohort, for instance? Because that is a completely unique potential we have. But I think there's huge mistrust.
Thank you. What an excellent question. And all of us involved in research will be absolutely rooting for the answer. We've just got massive, massive wealth that is totally underexploited. perhaps I can direct that, though it's not your...
Yeah, no, happily. I think you're right, and I think it's two things. We tend to think we have this asset called a National Health Service, but actually we don't have a national data set. Partly for the reason you describe in terms of societal trust, but also because we don't have a lot of the underlying infrastructure and data systems to have data transferability and ease of access. And so while it's hugely tempting, I think, for everyone to talk about the power of AI, if we don't have the underlying infrastructure in place, the AI's got no data to do anything with. And so I would add to your point around building up societal trust. I'd also say, as an NHS, which is much more within our own gift, working out how we get interoperability, interreadability of different systems across the NHS so that that data is easily accessible. So take that in terms of pathology and radiology, for example. We need to have much more standardised hubs and spoke systems so that the data is pooled. And then on the trust and the ethics, I've done quite a lot of stuff on this with my House of Lords digital hat on. I think that as a society, we need to have a much more open debate about the ethics of data. I think that we need to treat it not unlike the way human fertilisation and embryology was treated 30 years ago with the Warnock Commission. Because I think there's a danger that the tech is running ahead of societal hopes and fears. And if we don't proactively engage in that discussion quickly, society becomes afraid of things that they shouldn't and unaware of things that they should. And I think we're in the foothills of that already if we're not very careful. So there's a green shoots in the government setting up the Data Ethics and Innovation, or Centre for Data and Ethics and Innovation. That's still within government, so I don't think that's really the right place. I think that Dame Mary Warnock is a very good role model of something outside government that widely consulted and debated. And as a society, we landed on a settled view of the ethics of research in that area, and as a result we benefited hugely and other countries didn't. So I think you're totally right, and we need to lean into it at a national level pretty quickly.
Is just to follow up on that, what's the interaction, if I can ask, between NHS Improvement and NHS Digital on these issues? And is it to do with technical piping, or is it mainly to do with trust around IG, information government issues?
I wish it was only one. I think it's definitely both. And I think I've come into the NHS believing fundamentally that we can't really do anything unless we choose to collaborate. Yeah. The need to collaborate nationally with the national arm's length bodies is every bit as important as it is for local healthcare organisations to collaborate. That's the only answer if there is one. And so I would say we are in the sort of green shoots of working out what that will look like in terms of much greater collaboration, both with NHS Digital and NHS England. In theory, we have joint appointments looking at the digital transformation in the form of Simon Eccles as CCIO and Will Smart as CIO. In practice, I actually don't think that NHS Improvement has been on the pitch enough. And we need to engage much more actively in the work with NHS Digital and NHS England. And we've got to organise ourselves to do that and to play the role that the door is actually wide open. We just need to choose to walk through it.
Yeah, you kind of worry that we're going to be overtaken by events with the big tech companies who are very used to extracting consent out of all of us to somehow link that to consent for electronic records and monetize. And somehow that door is always open, doesn't it? Whereas what the NHS can do seems to be eternally blocked, and yet we're sitting on this massive oil lake, if you like, of data.
And I think it's about respecting the fact that rightly people working in the NHS are risk averse. This isn't really critical services we're talking about. I don't for a moment underestimate the challenges and the complexity of a much more sophisticated world than the one I've been used to. But we have to lean into it rather than expect that, if you look back over the last 300, 400, 500 years, the history of tech innovation is not that anyone ever succeeds in stopping it. Mm-hmm. If you choose to stop it in your geography, people will just go elsewhere. And that's, you can look through lots of examples of that, from the Ottoman Empire banning Arabic printing presses all the way through to the German boatmen sinking the first steamboat as it sailed down the Nile. And so it's a huge mistake just to say go away. It's equally, as you say, really dangerous if you create this asymmetry.
Yeah.
But if you talk to the guys at DeepMind, their biggest frustration is not actually, I don't think, really about the specific about data governance. It's much more that we're in the mainframe and laptop world, and we haven't worked out that these are the things that will make the difference. That, every time I go round a hospital and I see that people have different names for them, but basically laptops on wheels, I go, whoa, I'm really sure these things called tablets were invented quite a long time ago. And one of the nurses trialling the DeepMind Streams product in the Royal Free was showing me it on her iPhone, and we were walking through the corridor towards a patient, and she was showing me on the screen and saying how amazing it was and how it was real-time alerting, and it was saving real-time that enabled her to be with the right patient at the right time to make a judgment. And she said to me, it's amazing. No one seems to mind that it's on my mobile phone.
Yeah.
And I went, no, because when we walk out this building, we do everything on our mobile phone. Mm-hmm. So I think there's a big mind shift that the NHS is yet to make, that in terms of recognising that this is our friend, and that if we tame it, it can make our lives better, and if we try and avoid it, someone else will do stuff to us.
Good, thank you. Jackie, did you want to come in?
Yeah, just a sort of really brief point, because I think that you've summarised some of the issues very, very well about more effective collaboration on these issues. But I go back to the theme of this conference, which is about how to support the workforce and make improvements at pace, and the absolute necessity to understand that we can't make intelligent decisions without robust data. It's impossible. What kind of decisions or what kind of thinking are you making running down the road to AI and innovation and whatever, if you're not really utilising the data to say what's kind of like really happening? And this is where the patient experience and stuff actually really comes in. I know that in other industries, the customer is, at your industries that you're coming from, where the customer's viewpoints, the customer experience is actually the critical thing, really valued. And yet in health services, it's the minor thing. And so how do we bring that to more to be at the centre, actually, of our thinking and decision making? So I think, like, for example, with one of the things with the secure transformation that we did was actually make sure we use NHS benchmarking data. So we pulled that data together and really looked at the information in all different sort of like ways to make sure that we incorporated looking at it through the lens of age, gender, ethnicity, age, gender, ethnicity predominantly, and look at that data alongside the patient experience through the qualitative research, and look at that together to inform our design thinking, which then led to some innovative prototype models that we're now piloting. Now, we wouldn't have got to that, which is more in tune with what's being experienced, without actually the data. So how do you get to a more intelligent response without really using that kind of so what I would like to get to is a place where that data is much more fluid in terms of NHS Improvement and NHS Digital, and less like a years old and 20 years old and whatever, and we're still back in the day, but something which is more current and live and moving. Yeah.
Can I just add, the other type of people data that really good parts of the NHS use brilliantly and less good. So the CQC would show that the most important leading indicator of quality is the staff survey. And yet, when I go round and I ask my own teams and leadership teams out in the NHS, the granular understanding of what their staff in different parts of their organisation are saying and feeling is not as good as I would expect it to be. Yes. So whether it's the staff survey, whether it's absence rates, whether it's retention rates, what's happening, your people are telling you if they're engaged or not, but we're not really listening. And the data is there. And so I think I totally agree with you about listening to the patient voice, but I think often your frontline staff can tell you what patients are feeling too. And the real art is in having the courage to hear it.
Yes, both. Absolutely.
Thank you. More questions? Yes, thank you.
Thank you. Is it on?
Yes.
Oh, it is. Sorry, I'm not speaking directly into it. Andrew Johnson, I'm a non-exec with University of Leicester Hospitals Trust. And I used to manage food manufacturing businesses supplying your sorts of retailers, Dido. So and this is my first position in the NHS, so 2.5 years in, and I'm still learning what's possible and not what isn't possible. I agree with absolutely everything that's been said about big data and the use of data, and eulogising about and strategising about this is quite important to think it through. But as a non-exec in an operating acute trust, I'd like to bring the conversation a little bit back to the ground, frankly, because we're in danger of thinking that everything's wonderful. And one of the big disparities that I think is getting wider in the NHS is the ability of trusts to deliver for the patient based on the technology they have in-house. So, for example, and this isn't an advert, but at Leicester, we are still carting patient records around on paper in shopping trolleys. And so the disparity between what you're talking about, which is absolutely right in terms of use of data, use of mobile phones and beyond, because we'll get beyond mobile phone technology shortly, in reality, I think one of the things we need to reflect on is that the NHS needs to catch up the current organisation and the way the 147 trusts in England work means there is a massive disparity between good and not good.
Can I just, thank you, can I just turn the question on back to you for a second? You're a non-exec in this organisation. How do you think that this situation still prevails? Is it because of raiding the capital budget? Is it, what's happened so that you're still using the trolley and the paper records from your position on the board without obviously betraying confidences?
No, I'm quite prepared to talk about that. I think there's a disparity at the moment between NHS England and NHS I think there isn't a unified view of the policy of how trusts should be managed. So if you like, again, if I'm talking about food manufacturing, you think about the supply chain. In the NHS, we don't have a unified view of the supply chain all the way through from one end to the other because it's interrupted by two different regulators. And therefore, there's a lack of consistent policy on the standards, the minimum standards that need to be applied. And that relates all the way back to the patient because the patient trusts hospitals to give them the best care. And I think there's a lot of catch-up to come at the moment before we get in the position of being able to exploit data in the way we've just been talking about.
And so I just want to turn to Dido to say a few words on that just in 1 second, but just one further question. Just connect for me the disconnect between NHS and I&E and the trolley.
Yeah.
Okay, so
That's good.
the NHS allocates a certain amount of capital to be used in the NHS per year. NHS England regulate the commissioners. NSSI regulate the acute and the community trusts, effectively. So that pot is split. There is a combative relationship between commissioners and acute trusts, and I perceive there is a dysfunctional relationship, let's put it like that, between NHSE and NHSI. I have no evidence for that, I have to say. That's an assumption based on previous life. But so I think what's connecting to the shopping trolleys is that, I mean, for example, Leicester put a proposal in 4 years ago for a patient record system that was electronic. It took 2 years to get a no response to that. And I think in discussions on that, what I would reflect on is the NHS, as in NHSE plus NHSI, don't have an overview of the standards that every single acute and community trust, in my case, because I'm in an acute trust, should aspire to and be able to reach. So there's no view, there's no consolidated view on the standard of data processing and data management. And I think that lack of a consolidated view means there is a lack of direction and lack of leadership.
Okay, thank you very much for elaborating. And we also live in a system where, as well as we have the shopping trolley in Leicester, we also have state-of-the-art at other trusts as well. I'm just thinking of Addenbrooke's, for example, with the system that they've chosen, and many others also. So we've got enormous variation. Whatever the context, national context that you're describing, there is still a large variation between trusts, and some trusts are really ahead of it and some aren't. Dido, there's a bit of a challenge there. Gauntlet, you may want to say a few words about this.
Yeah, let me take the NHSI, NHS England thing. I think on a good day, the feedback I've had in the last 6 months is the NHSI team and the NHSE team will ask a trust or a STP roughly the same question in slightly different ways and ask them to fill in separate forms. That's a good day. On a bad day, they ask the same organisation to do directly contradictory things and encourage them to have a fight. And unfortunately, there are quite a lot of bad days. So I think your characterisation is not wrong. And I've come into this job with the express intention of trying to change that. So actually, I spent about 45 minutes before I came in here out on the pavement and a long conversation with Malcolm Grant, the chair of NHS England. We have our first joint NHS England, NHS Improvement board meeting tomorrow and Thursday. The two boards getting together to review how we're going to work together. And I think the only answer is what we're asking people to do in local health economies, which is to collaborate. Now, the legislation is clear that we have to retain separate boards, separate chief executives, separate chairs, so it's not straightforward. But if you forgive my commercial language, I think it is entirely possible to do a joint venture. And we are intent on doing that. We will try and go really quite fast to do that because I think we're all very mindful that although our organisations in number are quite small, the impact we can have in, I've been describing it, in changing the weather in the system could be quite large if we could get our act together a bit better. I think that's not just structural, it's quite a significant cultural change needed as well. And those of you, changing cultures in your organisations will know that you don't do at the click of your fingers. So it's going to take us some time. But the two leadership teams, so Simon Stevens, Ian Dalton, the two CEOs, and Malcolm and I as the two chairs, are absolutely determined that we're going to do it and that we're going to set out a way of role modelling the cooperation that has to be the answer at a local system level as well. So high level, I really do agree with you and I hear you. And hopefully we'll be able to demonstrate very quickly that we're going to make some change.
Sorry, I just wanted to ask, do you see that dual commitment being equal on quality improvement, which is, so not management now, but frontline clinical quality improvement of the type we know that the system needs to be skilled up in, particularly clinical staff? Yes. And do you see that sort of, obviously Steve Powers has now got his job replacing Bruce as the medical director. I know he's very keen on this kind of thing, but that's obviously a function and feature of NHS Improvements that it's been trying to push. Are you going to try and colonise NHS England?
Yes, well, we have Adam in the room. He's been leading a lot of the work for us. I think the clue for us is in the name, improvement. And what we need to do is focus a lot more of our activity around improvement. You won't hear me talking about NHS Improvement as a regulator. We happen to have some regulatory tools in our toolkit, but usually using them is an admission of failure somewhere in the system. The power that we have to coach, support, cajole, inspire, share best practice is actually much more potent than our regulatory power, and all of them should be used to try and drive improvement. I personally think, and we've done quite a lot of work over the last 3 months with the help of McKinsey, trying to work through what are the actual levers that a 1,400 person organisation in the centre of a 1.3 million person system can actually use to drive improvement. And the most powerful lever we can use is people. In the leadership culture that we inspire and encourage, the people decisions that we either directly take in appointing chairs or in sitting on appointment panels for chief execs or medical directors or you name it, I think is the most powerful lever that we can pull. And we don't pull it, I think, in anything like as structured and thoughtful a way as we could, and we fully intend to. But another of the big levers is, as you say, a real belief in quality improvement methodologies on the ground and an encouragement and a focus of sharing standardised approaches that are working and encouraging rather than telling people to take them up. And so sort of shining a light on the work that Adam and his team have done, that the GERFT team have been doing in terms of clinical standardisation and improvement, has to be the future. And you know, we've got to role model that within ourselves. So you know, the harshest criticism I've heard of NHS Improvement is that we ain't much of a learning organisation ourselves, and I take that quite to heart. But no, if we're going to try and inspire and encourage the system to become properly learning organisations, we've got to learn ourselves, and together with NHS England, we've got to try and do that. So I couldn't agree with you more, Jennifer, that it's one of the most powerful levers that together we can pull, and you need the centre not to be telling you to do that, but creating the weather that encourages that behaviour.
Thank you. With patients and communities, as Jackie says, at the very centre of all of that. Yeah. I think we're out of time now. Please join me to thank our panellists, Jackie and Dido, and Claire in absentia. Thank you.